All right, everybody. Welcome to the Friendly Neighborhood Oncologist. And a special shout out to everybody in the community who wants to immerse in the Oncoverse. If you're not part of that community yet, please consider subscribing. It's always free and I'll never direct message you. Go ahead and smash that like button, get the Friendly Neighborhood Oncologist into that YouTube algorithm. And again, thanks for being here. So I'm a board certified medical oncologist and I practice in the suburbs of a major metropolitan city here in the United States, not far from a top medical school and top academic cancer center, both places where I spent significant amounts of medical training. And on a daily basis, I help my patients kick cancer in the you-know-what. And there's a lot of information out there and also a lot of misinformation out there. So the purpose of this channel is simply to connect patients and families or anyone interested to medical resources that are free and that are considered the gold standard of care. And as a caveat, I'm not your particular physician. Please consult your own board certified physician. Nothing I say should be construed as a medical opinion or a diagnosis or a recommendation for staging or treatment. I'm simply pointing out free resources that are available to anybody. Okay, well, we're going into colon cancer, and we're going to talk a little bit about early stage colon cancer today. Again, we're referring to the National Comprehensive Cancer Network Guidelines, nccn.org. I'm not a medical or legal representative of them in any means. They have copyrighted guidelines. I know plenty of people who are on the committees, but again, I'm not their medical or legal representative. So often I'll meet patients who already have a diagnosis of colon or rectal cancer. And when we're talking about colon cancer, we have another video that's already discussed prevention of ever getting colon cancer and screening, that if you're going to get it, catch it at an early stage. So unfortunately, some patients, despite all that, will be diagnosed with colon cancer, and they may have had a colonoscopy, imaging. We're going through the clinical staging, and let's say that the T size is not the worst, and the patients may or may not have metastatic disease to lymph nodes, but don't have any distant metastases. So this is the AJCC, or the American Joint Committee on Cancer, TNM staging for colon cancer. It's the 8th edition. And so we're talking about hopefully folks who have stage 2 or stage 3 colon cancer that has been resected. So let's go back up to the guidelines, and our conversation will typically revolve around these early stages for these folks. So let's say we have a patient who has stage 2 disease, but may have some other high-risk features. So again, these are the patients who, again, they need to discuss this with their own board-certified physician, who may, instead of having observation without having any high-risk features, they may be at a higher risk in this group, and therefore some adjuvant or treatments after surgery to prevent recurrence may be recommended. And then, of course, surveillance after that. In patients who have lymph node positive disease, who have reasonable overall survival, good performance status, otherwise are going to live a reasonable amount of time, a standard of care recommendation has still been FOLFOX chemotherapy or CAPOX, which is obviously similar with capecitabine substituted for IV 5-FU. So I'm not going to go into the particular risk benefits of each of these specific regimens. That's beyond the scope of this talk. And then we can see for surveillance, let's say patients have stage 2 or stage 3 disease. Again, history physical for every 3 to 6 months for 2 years, and then every 6 months for 5 years. Checking CEA, a lab test every 3 to 6 months for 2 years, and every 6 months for a total of 5 years. And we have to keep in mind CEA, you can have false positives. Not all colon cancers or rectal cancers may produce CEA, the carcinoembryonic antigen. So you can see that's still a mouthful. Imaging, even without symptoms, is recommended every 6 to 12 months for a total of 5 years for this general stage 2 to 3 population. But most importantly, colonoscopy less than 1 year after surgery. routine PET CTs are not indicated. There is some emerging evidence and clinical trials available for circulating tumor DNA as a means of detection in early stage disease where patients are being treated for curative intent. And again, I've touched on in an earlier video recommendations for lifestyle changes that can decrease the recurrence of colorectal cancer. All right, I'd like to thank everybody who wanted to immerse in the Oncoverse, and Friendly Neighborhood Oncologist is out. You all have a great day.